Good afternoon. Welcome to MSK TBL 13, Functional Anatomy of the Pelvis, Hip, and Gluteal region. In this session, we will cover the following learning objectives, and we'll take a deep dive into some of the key muscles, bony structures, and also some of the clinical applications of this region. The hip joint. The hip joint provides several kinds of movements and stability. The flexion extension. Flexion involves the movement of the thigh towards the anterior abdominal wall. This motion allows the leg to go forward as in walking or kicking. Extension is the opposite movement. This is where the thigh moves backwards and is relatively limited compared to flexion. It's constrained by the tension of several key ligaments. For example, the iliofemoral, pubofemoral, ischiofemoral, which we'll talk about in a second. Abduction refers to the moving of the thigh away from the body's midline, so stepping aside. Adduction is going to be the opposite, moving the thigh back towards the midline, for example, crossing your feet. Lateral or external rotation versus medial or internal rotation is opposites. The lateral external rotation involves rotating the thigh outward away from that midline, and the internal medial rotation is going to be towards the midline. The last one is called circumduction. Circumduction usually is where there's a circular movement that combines a mixture of flexion, extension, and also abduction and adduction. And the key point is the stability of this joint. The nominative bones, which is the composition of our pelvis, consists of three parts. There's the ilium, the ischium, and the pubis. These bones then form the lateral and the anterior borders of the pelvis. Several key bony protrusions that we want to highlight: the ischiotuberosity, as well as the anterior superior iliac spine, ASIS, A-S-I-S. The fusion timeline for this is usually until the third decade of life, and this fusion can have quite a bit of implications for bone stability and the movement of an adolescent during adulthood. The sacrum, key function, is a broad, thick bone that stabilizes the pelvis by fixating the spinal column, and it forms the posterior juncture by which the pelvic girdle stays. It provides crucial stability and integrity to the pelvis. Key pelvic walls include the ilium on the superior wall, the ischium on the inferior wall, and the pubis on the medial wall. These walls then create to combine the acetabulum, the depression that accommodates the femoral head, that creates the hip joint. The labrum is a thick ring of fibrocartilage lining the outer region of the acetabulum, and the function here is that it is about 20 to 23% ability to increase that stability between the two bones. Shown right here, the acetabulum. You can see right here the socket over here. The pubic symphysis is a fibrocartilage joint. And then we also have the sacrum right here that fuses together with the two innominate bones. Some of the protrusion structures of the femur. So the femoral head, this is the globular round area that is articular surface that spans over 180 degrees in diameter. Mostly composed of cartilage on the outer surface, covered with a layer of hyaline cartilage. The smooth tissue reduces any friction in the joint and allows a central depression where that key ligament called the ligament teres attaches to. The femoral neck is important. There are several key points I want to highlight. Number one, the angle of inclination. The angle between the femoral neck and the femoral shaft is important for diagnosing certain kinds of disorders and issues with the lower limb. Approximately, it's going to be about 125 degrees in the frontal plane, and the angle changes throughout the person's life, starting pretty high in terms of angle at birth, and then decreases as the body gets heavier and weight bears. So on the right side, you can see a normal angle of torsion over here, and then it changes. So over here, the anteversion, where the femur head is going to be more protruded anteriorly, and that angle increases. And if it folds down further and closes the angle in parallel, this is called retroversion. So the angle of torsion is described as a twist of the femur that's usually within the 15 to 20 degree range. And it represents that relationship between the femoral head and the shaft specifically. Okay, but this is key. We also have a couple protrusions. The greater trochanter, this projects laterally to the side on the femoral shaft. Serves as a critical structure for attachment for muscle, which we'll talk about in the later session. And also the lesser trochanter, which is a smaller projection that's towards the midline of the femoral shaft, and also provides an attachment for muscles. Several key joints that occur in the pelvis include the pubic symphysis. This is the anterior articulation of the two pelvic bones. This is a fibrocartilage thick joint that's not meant to be movable. And then we also have the SI joint, the sacral iliac joint between the ilium and the sacrum. And then we also have the hip joint, or also known as the coxofemoral joint. This is a ball socket joint that permits a majority of motion. So there's flexion, extension, abduction, adduction, internal, external rotation. And the range of motion is limited based on three key factors: the depth and the integrity of the acetabulum, the strength of the ligaments around the hip, and also several kinds of muscular support inside the lower limb. So let's take a look at the iliofemoral ligament first. This is the inverted Y ligament, and this plays a key role in stabilizing the hip joint. It has two main branches. There is a superior lateral aspect, and there's also going to be a medial inferior aspect. This ligament originates from the anterior iliac spine, the ASIS, the anterior inferior iliac spine, ASIS. And it has distinct functions based on the fiber. So the anterior region strengthens the anterior capsule, and its main function is to limit extension and external rotation. The superior fibers limit any kind of adduction, and the inferior limits the abduction. So it depends on which fibers are activated. The next one we have here is the pubofemoral ligament. Quickly going over this one. This is the sling or hammock shaped. It emerges from the pubic ramus, converges at the medial iliofemoral and ischiofemoral ligaments, and inserts to the anterior intertrochanteric region of the fossa. The main function here is that it limits abduction, hip extension, and also external rotation. The next one is the iliofemoral. This is located on the posterior aspect as a triangular shaped ligament. Originates and attaches to that joint capsule near the greater trochanter. It limits mainly hip extension. And then we also have the annular ligament, also known as the zona orbicularis. This one encircles the femoral head in a compact circular fibers. It's also intertwined into the ischiofemoral ligament. The function here is it distributes the synovial fluid in the joint capsule. This is helpful for lubricating the joint. Plays a role for stability as well as helping keep it intact. This also goes for the ligament teres. This is the one that's located within the actual head. And the main key function is that it's a conduit for proprioception, so it actually perceives pain and does provide a role to supply blood flow to the head of the femoral head, of the femur. Over here is a visual showing you that. Over here on the right we have cadaver, highlighting the iliofemoral ligament, pubofemoral ligament on the right side, and then right on left we have a cartoon image showing you the fiber striations. So notice the way the fibers span from the bone to the insertion. Okay, and on a cadaver it is a little trickier to see, but you can see that the fibers do run in one direction, and depending on an injury, if it is anti-parallel to the fibers, the recovery will be tremendously impaired. Here is a quick little cheat sheet for you as you're reviewing. I listed out the ligaments that you need to know and the key function as far as what motions it restricts. So what does it prevent from overdoing? There's a comparison of male versus female pelvises. The male pelvis is thicker and heavier. For female, it's a little bit lighter and thinner. The greater pelvis region major is deeper, and then for the female, it's more shallow. Notice that the inlet also is different shaped. It is a heart shape for a male, while it's oval round shape for a female. And the key region is the pubic symphysis arch angle. So it's usually going to be less than 70 degrees for a male. And because females are going to be birthing, there's going to be a need for a greater than 80 degrees. And then as a result, the acetabulum also changes shape because of the size of muscle mass and body mass. Arterial supply of the pelvis. So key supplies here are there are 4 arteries in the female and 3 in the male. They're paired internal iliac arteries. They divide into the anterior and posterior divisions. For the females, we have the paired ovarian arteries that we don't have in the male. And for both, we have the medium sacral artery and then the superior rectal artery. So on the right, you can see the passageway. This is a sagittal view of the abdominopelvic region. And as the common iliac courses down, it splits into the internal and the external, and it wraps around. As far as the venous drainage goes, it is exactly the same. It mirrors the arterial system. And there's a network that interjoins the veins in the pelvis region. So this includes plexuses like the rectal plexus, the vesical prostatic for the males, and then for the females, we have the uterine and the vaginal. Okay, so uterine and vaginal are only for the females, and then the prostatic is going to be for the male. Let's take a look at the femoral triangle and the adductor canal. So the key features of the femoral triangle is as follows. So this is location appearance. This is a triangular region situated right below the inguinal ligament at the upper part of the thigh. It forms a distinct triangular depression, and it creates this noticeable region when the thigh is flexed, abducted, and laterally rotated. So when you do that position, you can see a little bit of that triangular impression. The boundaries here are going to be your inguinal ligament superior, the adductor longus medially, and sartorius longest muscle of the body on the lateral side. At the muscular floor, we're going to have the two key muscles, the iliopsoas, that's the hip muscles for moving and walking on the lateral sides, and the pectineus, that's used and situated more medially. The retroinguinal space is going to serve as a conduit for key structures for passing through the abdomen and the thigh. So for example, the femoral nerve, the femoral artery, femoral vein, they pass through this region right here. The adductor canal is also known as the Hunter's canal. This is a critical passageway for the thigh that transport key neurovascular structures. It's located towards the apex upper region of the femoral triangle to the adductor hiatus and also through the adductor magnus. Similar structures that it's going to include the femoral artery that supplies blood to the lower limb, passing transition into the popliteal artery towards the knee, the femoral vein running alongside the artery, then drains back towards the heart, the saphenous nerve, which provides sensory information towards the medial aspect of the feet, and also the nerve to the vastus medialis. This is going to innervate the vastus medialis, one of the quad muscles for extending the knee. It should be noted that even though the femoral nerve, it is the largest one, not directly in the canal, is key for thigh function. The obturator artery and nerve pass through the obturator foramen, and that then supplies the adductor muscles. The lumbar sacral plexus. The lumbar plexus is formed from the anterior rami of the spinal nerves L1 to L4, and it's a key structure in the nervous system. It provides motor and sensory innervation to various parts of the lower body, including the thigh and portions of the abdominal wall. The femoral nerve has a key position being towards the posterior side of the lumbar plexus. It innervates the anterior thigh muscles, which are responsible for extending the knee. It provides sensory input also from the anterior and the inferior medial parts of the thigh, as well as the medial leg. Then we have the obturator nerve. The obturator nerve is going to be located on the anterior side of the lumbar plexus, key function, and that's the main nerve of the anterior division. It innervates your medial thigh muscles involved in adducting, and provides information towards the superior medial skin of the thigh. Then we also have some of these smaller nerves that innervate the abdominal wall, for example, the regions that branch out to the external genitalia, and they contribute to regions of the abdominal muscles and also sensory input towards the genital regions. Here's a mnemonic that helps you memorize the lumbar plexus. So the mnemonic goes as follows: I twice get laid on Friday, luckily. And the nerve roots are as follows: 1, 1, 2, 2, 3, 3. So you can see right here that it's going to be I stands for iliohypogastric, twice, 2 times, 2 letter I's, ilioinguinal, get genital femoral nerve, L lateral femoral cutaneous, O obturator, F Friday femoral, L luckily lumbar sacral. L1, 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 2, L2, 3, 2, 3, 4, 2, 3, 4. So these are the number of roots that come from it. And so it's not too bad. 1, 1, 1, 2, 2, 3, 2, 3, 4, 2, 3, 4. And that is your entire set of lumbar sacral nerves. So the sacral plexus is also a critical region. It's going to be located towards the posterior lateral wall of the lesser pelvis. It's nestled closer to the piriformis muscle, pretty deep inside. And this plexus plays a key role for innervation of the lower body's leg, feet, and the pelvic area. Key nerves here are the sciatic nerve, L4 to S3. This is the largest one in the body. It's responsible to branching out to the posterior thigh, leg, and the foot. So extensors, everters, and it exits the pelvis via the greater sciatic foramen. That's a key passageway that opens up, and it makes a critical signal down to the lower limbs. The pudendal nerve is going to be essential for the external genitalia and the perineum, passes the lesser sciatic foramen. and also is involved in both sensory and motor function, so controlling the muscle and also the bladder and the bowel. The SGN, superior gluteal nerve, originates from the spinal segments of L4 to S1. This one key innervation is going to be the gluteus medius and the gluteus minimus, as well as the tensor fasciae latae muscle. These muscles play a critical role for stabilizing the pelvis for gait, lateral rotation, as well as abduction. The inferior gluteal nerve, IGN, arises from the L5 to S2. It's responsible for innervating the powerful gluteus maximus, a key player for hip extension, particularly for climbing stairs or rising from a sitting position. Then we have the PFC, posterior femoral cutaneous. This one contributes to S1, S2, S3, provides sensory innervation to the skin of the buttocks and also the upper regions towards the medial and posterior surfaces of the thigh. Then the last one, again, is the pudendal nerve, S2, S3, S4, serves both as a sensory and motor function, and it sends signals to the genitalia and also innervates the perineal muscles. It plays a key role for the control of the pelvic floor muscles, for example, controlling urination and fecal continence. Key nerves to be aware of. And here is a quick snapshot chart that goes over the key nerves and then the nerve roots, as well as briefly which muscles it innervates. So make sure you study these key items. All right, let's jump into the gluteal and posterior thigh regions and talk a little bit about the ligaments and muscles. So ligaments of the hip pelvis, we'll start with the posterior sacral iliac ligament. This connects the sacrum to the iliac bones of the pelvis. Inferiorly, it blends with the sacrotuberous ligament that contributes to the pelvic stability. You can see right here, this is the posterior sacroiliac ligaments, and it glues it directly to the vertebrae. The sacrotuberous ligament extends all the way from the sacrum past that sciatic notch, all the way down to the ischial tuberosity, which is the region you sit on a chair, and your pelvis is attaching towards the chair, and it helps form the boundary of that lower lesser sciatic foramen, shown in yellow. We also have the sacrospinous ligament. This extends from the ischial spine of the sacrum. It converts to the greater sciatic notch and then into the greater sciatic foramen. So it's on the left side, shown here in the yellow structure over here. Keep in mind that the greater sciatic foramen is the passageway for the sciatic nerve, and the lesser sciatic foramen is the passageway for the pudendal nerve. There are plenty of bursae, these small fluid-filled sacs that form cushioning that reduce friction, and bursitis can affect the lower limb as well, particularly around the joints, and these are lined with synovial membrane that are important for smooth, pain-free movement. There are several of them we'll talk a little bit about. The trochanteric bursa, this is the bursa located over the greater trochanter of the femur. Its main cushion is to stabilize the gluteus maximus muscle as it moves towards that bony prominence of the greater trochanter. Then we also have the ischial bursa that cushions from the ischial tuberosity, and it's important because it involves activity and kind of squeezing motion when you're sitting. The gluteal femoral bursa is going to lie between the iliotibial band and the superior portion of the vastus lateralis. The quad muscles on the outer side sweep of the leg, and it helps cushion and reduce the friction between these structures during any kind of movement. So over here, the trochanteric bursa, the gluteal femoral bursa, and then the ischial bursa shown in the purple regions. Be familiar with some of the key actions and what muscles do that. So for the lower leg, the abduction muscles are going to be your gluteus medius and minimus, assisted by the sartorius, TFL, tensor fasciae latae, and piriformis. Adduction will be your adductor muscles, so adductor magnus, longus, and brevis. Lateral rotators are going to be your piriformis, obturator internus, OI, obturator externus, OE, superior inferior gemelli, as well as quadratus femoris, and of course your gluteus maximus. And then the main medial rotator of the lower leg will be your gluteus medius and minimus paired with your TFL. Your gluteus maximus is your main hip extensor. So right here showing you in a visual that the muscles located on the posterior side generally overlap with the extensor and lateral rotator, and then the muscles on the interior generally are going to be your flexors with your adductors on the lower side, and the ones a little bit upper are going to be medial rotators and abductors. So this is a great way to divide up the action to the location of the origin of the muscle. So let's take a look at the first muscle of the list. The first muscle is the gluteus maximus. The proximal attachment will be the superior ilium, specifically along the anterior gluteal line. It also comes from the posterior sacrum and the coccyx. The proximal attachment, or the origin, is the region of least movement when contracted, and the distal attachment will be gluteal tuberosity of the femur, and also through the fibrous band of the iliotibial tract. The key innervation here will be the IGN, inferior gluteal nerve, L5, S1, S2, and key actions to be specific about are hip extension, external rotation of the hip, and then the lower fibers provide adduction, and then the upper fibers provide abduction. Gluteus medius muscle. This is the one that is going to have a proximal attachment of the superior ilium and also the anterior gluteal line. The distal attachment will be the greater trochanter of the femur. And the innervations are as follows: the superior gluteal nerve, SGN, L4, L5, S1, overlapping with the tensor fasciae latae muscle. Main functions for this muscle is that it allows hip abduction, hip flexion, internal rotation, external rotation, and even hip extension to some degree. Okay, but the main function is more of the medial rotation or internal rotation. This is the main key function here. Shown here, the medius right here, the fibers, and then the medius is underneath that. Next one will be the gluteus minimus. This originates from the lower ilium, margins of the greater sciatic notch. Distal attachment will be the greater trochanter of the femur, and the innervation will be the superior gluteal nerve, L4, L5, S1. Similarly with TFL, main function will be the hip abduction, hip internal rotation, and hip flexion. Here is a cadaveric image showing you those two muscles. So on the left side, we have the gluteus minimus, deeper within, extrapolated out, removed tissues and muscle fibers, and on the right side, we have the gluteus medius. So this is a real cadaveric dissection of the lower limb. Let's take a look at the TFL, tensor fasciae latae. This one originates from the ASIS as well as parts of the iliac crest on the upper part of the pubis of the pelvic bone. Distal attachment insertion will be the iliotibial tract, and then the innervation will be the superior gluteal nerve, L4, L5, S1. Key functions here is that it provides hip flexion, hip internal rotation, medial rotation, as well as hip abduction. So it overlaps with the medius minimus. These three are your main medial rotators. In a clinical aspect, when the iliopsoas muscles from walking gets paralyzed, the TFL takes over and oftentimes will undergo hypertrophy and thickening. Then we have the obturator internus and the obturator externus. OI, this is going to be the origin of the obturator membrane in the pelvis region. Distal attachment will be the greater trochanter of the femur, and the innervation will be the obturator internus L5, S1, S2. Main actions here are external rotation, and it passes directly through the lesser sciatic foramen. So in case that the lesser sciatic foramen gets damaged or pinched, the muscle could also be damaged and affected. Let's take a look at the piriformis muscle. Piriformis attachment, it begins in the proximal region, origin of the pelvic surface of the sacrum, upper rim of the greater sciatic foramen. Distal attachment will be the greater trochanter of the femur, and then this one directly is a smaller nerve branch, S1, S2, called a nerve to the piriformis. And the main function is that it is a hip external rotator, overlapping slightly with the obturator internus, superior gemellus, and inferior gemellus. Shown here, right here on this visual, you can see the piriformis muscle, and the piriformis syndrome is when this muscle gets pinched or compressed via a postural issue or overuse. All right, the superior and the inferior gemelli muscle. The superior gemelli originates from the ischial spine, and then the inferior gemelli comes from the ischiotuberosity. They both share a distal attachment at the greater trochanter of the femur via the obturator internus tendon. Be mindful that the innervation is different. The SG, obturator internus, comes from L5, S1, S2, and the IG comes from L4, L5, S1. These are main hip external rotators. Together, the OI, obturator internus, with the SG-IG are paired as the triple triceps coxa of the hip. And it occupies that gap between the piriformis and the quadratus femoris. And oftentimes, when any of these muscles get inflamed or injured, it can cause pain. The next one is the quadratus femoris. This is a short, flat, quadrangular muscle, hence the name. Origination, it comes from ischiotuberosity. The distal attachment is the intertrochanter crest of the femur. And there is a nerve of the quadratus femoris, NQF, that is going to be the L4, L5, S1 root supply. Main function is a hip external rotator. Shown here, it's a little bit lower on the inferior region. Over here I have a cadaver image showing you those two muscles. So on the left hand side we have the piriformis dug within, and then on the right side we have the obturator muscles as a set. Notice that the obturator externus will be talked a little bit more in depth in DSA 6. Then we have the ST and SM, semitendinosus and semimembranosus. The proximal attachment of the ST-SM is going to be your ischiotuberosity. The semitendinosus medial distal attachment is going to be superior tibia, and then the semimembranosus is the posterior medial condyle of the tibia. This forms your hamstrings. The key innervations is that it comes from the tibial division of the sciatic nerve. Specifically, the semitendinosus is L5, S1, S2, and semimembranosus is L5 to S1. Main functions here include hip extension, hip internal rotation, slight knee flexion, and also internal tibial rotation. The bicep femoris has two heads. We have the long head that originates from the ischiotuberosity, and the short head comes from the linea aspera. The distal attachment is going to be the lateral side of the fibula and also parts of the lateral tibial condyle. The long head is going to come from the S1, S2, S3, and the short head comes from the L4, L5, S1. Main function here is a hip extension, hip external rotation, knee flexion, and also external rotation of the tibia. Here is a picture showing you the hamstring muscles dissected. This is the tendinosus on the left-hand side, and then shown in purple, and then we have on the right the semimembranosus muscle on the right. Let's take a look at the adductor muscles. Adductor brevis, longus, and magnus. We're going to abbreviate that as B, L, and M. The brevis comes from the pubic ramus. The longus comes from the pubic symphysis towards the midline, and then the magnus comes from the inferior pubic arch, the inferior pubic ramus. The distal attachment for the brevis will be at the pectineal line, and then the longus attaches to the medial 1/3 of the linea aspera on the posterior side of the femur, and then the magnus is going to come and attach to the gluteal line of the adductor tubercle. The nerve innervations are as follows. They all come from the branch of the obturator nerve, so it's L2 to L4, and then for the magnus, there's going to be parts of the sciatic that also branches supposed to be from L2 to S1. Main function is hip adduction. Over here you can see the picture of the muscles. Clearly seeing that the adductor magnus is palpated right here. Brevis is a little bit further lateral, and the longus is in the middle. Let's take a look at the rectus femoris. This is going to have a proximal attachment of the AIIS, anterior inferior iliac spine, and the distal attachment will be the tibial tuberosity via the patella ligament. The main nerve roots are going to be the femoral nerve from the L2 to L4, performs the hip flexion and the knee extension function. So over here on the right you can see the rectus femoris muscle deep within. Then we have the gracilis and pectineus. The gracilis is the proximal muscle most medial. Pubic symphysis and distal attachment goes to the medial tubal flare. The main nerve that it supplies from is the obturator L3 to L4, and the key function here is the hip adduction and knee flexion. And then the pectineus also plays a role for hip adduction, and this one is going to originate from the pubic symphysis, and distal attachment will be the pectineal line of the femur, and then also same sharing the L3 to L4 region. So gracilis over here on the medial side, and pectineus a little bit more lateral, superior. The final muscle that we have here is the sartorius. This one is going to originate from the ASIS, anterior superior iliac spine. Distal attachment will be the proximal portion of the anterior medial tibial flare, and then the femoral nerve is going to be from L2 to L3. Main functions are the hip flexion, hip abduction, hip external rotation, knee flexion, and also slight internal tibial rotation. Shown here is the sartorius muscle, the longest muscle of the lower leg. Spans from the pelvic region all the way down to the tibia. Here is a snapshot of a key chart that shows you the action of the muscle and where they fit. Notice that the boldface word, so the gluteus maximus is the prime extensor, and the iliopsoas is going to be your plantar flexor. All the other ones are going to have similar functions, but I just group them together so that when you're studying, you have a quick list to know what falls into which category. Now let's take a look at some clinical applications. The first one are hip fractures and types of risks. The type 1 kind of fracture in the hip is called a transepiphyseal fracture. This is a pretty rare incident comprising of about 8% of pediatric hip fractures. Complications oftentimes will result in high risk of osteonecrosis, where there's pretty much damage guaranteed. The key considerations related to this will be patients that have hypothyroidism, and there is an issue with the metabolism of macros, the hypogonadism, when there could be also issues with testosterone and hormones, and also renal diseases. Type 2 is called transcervical fracture. This one occurs where it's the most common, making up about 45% of all the pediatric cases, and the complications here are the osteoporosis occurs about 50% of the cases. Type 3 is called the cervical trochanteric fracture. This accounts for about 30% of pediatric fractures. They're more common in children than adults, and it does have significant risk factors. And type 4 is the intertrochanteric fracture, which is the remainder types of fractures, and then the complications are slightly lower because there's still quite a bit of blood supply, and so the healing process isn't as bad. There's actually lower risk of complications due to a more abundant vascular supply. So on the right we have pictures of it. So type 1A and 1B fall into transepiphyseal. So right here you can see either the top part of the head gets cut off or part of the head is severed. Type 2 is transcervical, so you can see it's by the neck region. Type 3 will be at the base of the neck, closer to the greater trochanter, and the intertrochanteric is through the trochanter and cutting through the femur head. Fracture, particularly involving the neck of the femur, is pretty severe and oftentimes could impact the quality of life. So when you talk about individuals over 60 that are non-pediatric, largely these fractures are due to physical activity or insufficient taking of calcium and vitamin D or issues with your body weight. So some pathophysiology could occur. The neck of the femur is critical for the blood supply to the head, and so whenever the fracture occurs, usually the culprit is the medial circumflex femoral artery and also the reticular arteries that oftentimes get damaged, and that disrupts the blood flow. As a result of these damage, it leads into what we call AVN, avascular necrosis of the femoral head, where the bone tissue begins to die off because of lack of blood. Some of the complications of AVN include blood clots and even pneumonia, reduced mobility because of prolonged bed rest, and also muscular atrophy. So over here is showing you that the key vessels that get torn are oftentimes the medial circumflex femoral retinacular arteries. Another clinical test is called the Trendelenburg sign. This is whenever the hip abductors, or primarily the gluteus medius and minimus, get impaired. Because these two muscles play a key role for stabilizing the pelvis during walking, running, and other movements, and ensures that the pelvis remains level when one leg is lifted off the ground. So whenever there is an injury to the superior gluteal nerve, these muscles are oftentimes significantly impaired. So one way to test for this is the gluteus medius and minimus functionality test, and you can see if they are working together or if they're paralyzed or weakened due to their ability to stabilize the pelvis. So how it works is that in proper positioning of the femoral head, the head of the femur is going to be securely tucked into the hip socket. If there's any kind of displacement or subluxation of the femoral head, this will disrupt the biomechanics of that joint. And as a result, one of the key symptoms is going to be what they call gluteal or waddling gait. This is a compensatory list of actions that help you balance back the weakened muscle or the weakened damaged nerve. So over here in the picture is the patient is going to be standing with their weight evenly distributed, usually anatomically positioned, and you're going to be viewing the patient from the back. So for example, in letter A, if we're testing for the left side of the patient, we will raise up right feet. If you are testing for the right hip, you will raise up the left feet. And in a case of a positive test, the pelvis tends to lower on the non-weight bearing side. So in this case, when you see the patient, the pelvis drops downwards toward the side of the leg that is raised. That will indicate that there is a weakness in the muscle. As a result, the muscle over on the left side is the one that's damaged. So you would test for the left side, and if it drops, whichever side it drops to, the opposite side muscle is damaged. Another clinical application is simple inspection of the patient's legs, and some signs include Bunnett's position. This is when a patient might state into a flexion, abduction, external rotation, just to reduce any kind of pain. Sometimes abnormalities could develop as a result of the femoral head and shaft angle that we talked about. The first condition is called coxa valga. Coxa valga is oftentimes where the leg is shifted so that the position of the patella kneecap is more lateral. Oftentimes, patients that have genu varum, knee are opened up, this can happen. And then we can also have coxa vera, which is called genu valgum, where the knees are not or bow-legged. And this oftentimes will impair the gluteus medius muscle and this function. Another way to measure this is you can also have the patient lie on a bed, and based on the anteversion retroversion angle, and you can see what kind of motions are limited. So in this case, a patient lies down on a testing bed, and then the lower leg is extended up, and the anteversion, whenever there's a greater than 20 degrees, that means the internal rotation, as well as there's going to be limited external rotation and increased internal rotation as a result. In retroversion, where the angle is lower than 15 degrees, oftentimes there's going to be a toe-out gait, and then the patella tends to be shifted laterally. This reduced, and as a result, there's going to be reduced internal rotation and more extreme lateral rotation. Let's talk about two diseases and conditions. The one is called the snapping hip syndrome, the coxa saltans. This hip syndrome occurs whenever there's a palpable audible snapping sound within the hip during flexion or extension. Oftentimes it's caused by the IT band sliding over the greater trochanter, and symptoms is a result of a lot of pain. As a result of this, there are usually two causes, the external or internal. External causes is whenever the IT band slides over the greater trochanter, causing a snapping sensation and pain. And then the internal cause is when the iliopsoas tendon passes over the femoral head. Usually a radiograph or MRI is used to rule out any kind of lesions or other kind of hip angulations, but some other differential diagnoses could be stuff like subluxation of the hip joint or even trochanteric bursitis. The last one is piriformis syndrome. This is caused by spasm or hypertrophy of the piriformis muscle. Whenever there's a compression of the sciatic nerve, this can occur, and oftentimes this is more common in females than males. Creates a burning, numbness, paresthesia in the buttocks and lower leg, and usually gets worse when you're sitting for a long period of time. Palpitation, oftentimes of the sciatic notch, can increase symptoms, and the best way to test for this is a positive straight leg raise. So you have patients raise their leg up, and if they feel a pain, that means it's very likely there could be piriformis syndrome. The way to treat this oftentimes will be stretching, isometric strengthening, as well as sometimes Botox injections. In worst case scenarios, surgery.